You're listening to The Bridge, an original podcast from the Military Family Advisory Network, where we explore how leaders use data to impact the lives of military families. I'm your host, Shannon Razsadin, MFAN CEO. The Bridge is produced by rockITdata, a leading innovator in health data, AI, and technology solutions. Let's get to it. Hello and welcome to The Bridge. We're thrilled to have you join for today's episode. Over the next hour, we're going to have a conversation with key leaders in the healthcare space as we really uncover some of the data related to military family healthcare experience and really where the industry is going. At MFAN, it's incredibly important to us to make sure that we're using data and collaboration to drive meaningful change for military families. And so I am thrilled to have the experts here with us today to share their background, share what they're seeing, see where they see the space going, and really engage in a dialogue as we look to understand what's happening in the healthcare space as it relates to military families. So for us to get started, we're just going to go around and do brief intros. So you can introduce yourself, your background, fun fact about yourself. I'll get started. I'm Shannon Razsadin. I'm joining from Newport, Rhode Island area. My husband retired from the Navy in June of 2023, and I'm thrilled to be one of the co-founders of this organization, really focus on driving forward meaningful change as it relates to the areas that military families most need support. Dr. Malanoski, we'll go to you next.
Mike Malanoski, I'm the Deputy Director for DHA. I have been in the Department of Defense for more years than Shannon has lived. Started with ROTC at Holy Cross, then went and did 30 years as a physician with Navy Medicine. When I retired, I moved into an executive position within Navy Medicine. And the past 2 years, I've been the Deputy Director for DHA.
Amazing. Holy Cross is a great school. My sister, who is a surgeon, graduated from Holy Cross from undergrad. And so love that good Massachusetts DNA here. Dr. Moody, if you could go next, please.
Yes, I'm Ron Moody. I'm a retired Army physician, former Chief Medical Information Officer at MHS, currently serving as the Chief Medical Officer at Accenture Federal Services. As part of Accenture, and that's a global Accenture. We're a small part of Accenture Federal Services. We do only work with the federal government, and we've been supporting that military community, both on the VA and DoD side, for everything from health records to benefits and other activity. And I'm a Washington Lee graduate, but I am coming from the North Georgia mountains here today because it's always good to have a simple life after military retirement.
If you could please introduce yourself.
Yes, hi, I'm Alex Jahangir. I'm an orthopedic trauma surgeon here at Vanderbilt University Medical Center in Nashville. While I have not served in the military, from my college days at GW, all my roommates were Navy ROTC people, and I've had the real privilege of being able to be around a lot of colleagues and friends who have served in the military. And one of the things I'm most proud of as both a trauma surgeon here at Vanderbilt, but also the Senior Vice President for Provider Network Relations and our Associate Chief Medical Officer, is our ability to work really closely with Fort Campbell and Blanchfield Army Hospital to really make sure not only our military families are taken care of, but our men and women who serve also get the training that they need so they can take care of each other when they're downrange. So it's really a pleasure to be with you today.
About how we can facilitate meaningful conversations that cross from the federal space, the nonprofit space, to the academic space, to the corporate space. And so thank you all for being here for our pilot episode. We're really thrilled to have you. Now, I want to start broad and really look at the big healthcare landscape. As you all know, MFAN is really focused on taking data and driving meaningful change. It's something that is very important to us from our DNA perspective. We want to make sure that our research and our data does not sit on a shelf, but that it's really actionable for families. So to frame the conversation, I want to start broad, and this is for each of you. What do you see as the most pressing issue facing military healthcare these days? And Dr. Moody, we'll start with you.
I appreciate that. It's a great question. And I think sometimes when we start talking about pressing, we sometimes lose sight, right? So I think some of those pressing issues is really that there's a provider shortage. There's difficult access across the country, mental health or other. I think the numbers are 120,000 physician shortage by 2030 and an equal number of nursing and just mental health professionals. So I think part of as we stop and take a look at what are the most pressing issues, we have to say, what are the things that are in front of us, just like we do in war preparation? What is the war we're going to fight? And here, although the DHA provides excellent health care, it's really that we can't do more of the same. We have to come up with ways to do better differently, both for our training, our readiness, as was mentioned. And I think this is why Dr. Crossland really, at the heart of what she said about anytime, anywhere, always care. It's about doing things differently, better, right, to improve access, efficiency of what we do, not just simply say, I have an access problem. How do I hire more people, or how do I build more facilities, or how do I put more people into the network when that care and access may not be there? So I think that's the goal here, is how we make it better, but we have to do it differently.
Malanoski, from where you sit, what's your perspective here?
So I think when we talk about challenges to the system, it always comes back to resourcing and how you apply your resourcing against the mission set that you have. And we have two mission sets. We are responsible for the medical support of operational forces, and we deliver the benefit. And what we've seen, particularly over the past 10 years and accelerated by COVID, is challenges to the operating model that we have had for the past 30 years, which is a direct care system and a purchase care system that are integrated loosely, but really depend on the active duty to be able to man the direct care system. And so there are now pressures and challenges related to staffing of that system. In addition, as medicine continues to advance, some of those MTFs, our hospitals and clinics, are much smaller than you would see in the private sector. And so we have to look at what's the right footprint for the direct care system, and then how do we ensure that the patient has a continuum of care that is easy for them to navigate.
The military is a microcosm of the broader population, yet there are these nuances with military life that can make things more challenging at times, things like frequent moves. So Dr. Jahangir, can you share from your perspective what you see as the most pressing challenges?
Yeah, you just actually named the one that I think I've seen most closely with families, especially, is the continuity of care given the frequent moves, right? If you have a child that may have developmental disability or needs some chronic services, and they move from one location across the country, how do we ensure that that care is consistent and that the communication between facilities, whether military facilities to civilian facilities and vice versa, happens easily? And that, as many on this call know, is a little more challenging than I think we would all like. And so that interoperability and that ability to communicate amongst facilities is a really important one. The other component that I think is really, from where I sit as an academic medical center, is ensuring that our healthcare providers, whether physicians, nurses, advanced practice providers within the military, continue to keep the skills that they've gleaned in their education, irrespective of where they go. So as a trauma surgeon, I have the pleasure of working with a lot of military trauma surgeons. And when they go to the battlefield, do a lot of trauma, come back in a place like Blanchfield, where, thank goodness, there's not too much trauma on Fort Campbell's campus, being able to be a partner and ensuring that their skills are ready, both for them to be able to take care of the families and the people here at stateside, but also when they go down to deployment. That, to me, also seems to be a challenge that, as a civilian partner, we can try to help mitigate.
I know when we moved to Rhode Island, it took months for us to be able to get in with a pediatrician just because the appointments weren't there, the access wasn't there. So how we've defined access, I think, especially in a post-pandemic era, has really changed quite a bit. Dr. Malanoski, can you talk a little bit about how you at DHA are defining access these days and how you're really pushing the needle forward?
I think we have to start with what the system is and what it has been based on. And it is basically a provider-centric system, which most of the traditional systems in the U.S. are. What does that mean? It means the system is designed around the provider to make the provider as efficient as possible. The idea being, the more efficient the provider, the more appointments the provider can deliver. And so then your access becomes how many appointments the provider can deliver. The challenges in 2025 are, after a certain point in time, the ability to squeeze efficiency becomes rapidly smaller and smaller, diminishing returns. And then the only way you can improve access is to improve the number of providers you have. But as we already talked about, the challenges across the U.S. related to the provider pool is increasingly problematic. And so at DHA, we are shifting to a patient-centric model. What does that mean, practically speaking? It means instead of looking at the patient as an appointment, we look at the patient as, what does the patient need or want, and then what is the easiest, fastest way to deliver what they want to them. And very often it is not the provider. It can be somebody who's in front of the provider. It can be a bot. It can be a lot of different ways that technology now enables us to engage with the patient and give them what they need. And so that is the fundamental shift that DHA is making. We want to move to provider-centric if we talk about value-based, where it is how do we take care of the population with the limited resources we have, maintaining what the patients need, but at the same time balancing the dollars that we have against. That fundamentally is where DHA is going.
And yeah, and just to echo that, I think that is what we've learned through our work across federal healthcare as well as in a commercial world, right? With consumerism and digital engagement, it has to change, right? Access is no longer the third next available appointment. It's really from the patient perspective. It's what Dr. Malanoski was pointing out. It's what's the first time that you can meet my need in the most efficient way possible, in a way that I trust, which is key, right? So we see the big box stores, just trying to make convenient access is not really access if it actually just increases total cost or total utilization. So from the patient's perspective, you have to address that, what access is. And of course, that is because satisfaction is the most tightly coupled thing you see to satisfaction, and a willingness to follow the clinical plan, which is key for outcomes. Now that brings us back to capacity, right? The other side of the equation, which is what the health system can provide, right? And access is the efficiency of that use of the service so that it's available. If I have 50 beds in a hospital and they're not utilized tonight, I still have 50 beds tomorrow. So what can you change? You have to do. And by separating those two perspectives, I think we have seen with healthcare entities, we can easily help, solve the math problem, right? You can do the same thing, but you got to solve for the patient and the staff, because we, although we would like physicians to be available 24/7, we have to sleep too.
Thank you.
No, it's if I can just build on that. I mean, I think as we mentioned, availability, affordability, and timeliness. I think for families, with TRICARE, I mean, sometimes affordability can be an issue. If I can build further upon this access discussion, is I think that the three of us and maybe the four of us actually all, when we think about access, I think about my primary care doctor that I want to call and set up an appointment and go see that person. And she's going to make a recommendation and a referral to another person. And then we'll go to their clinic and then we'll sit there. Dr. Moody said, this is different now, right? Like if Amazon has access now through One Medical, right? You can go online and for somebody who's in their 20s, they may not want a primary care doctor that they have a long-term relationship with. They very well may just want to be able to quickly get on their phone, text a question, and get real medical advice, and then get their drugs sent if there's a thing that needs a medication. Telehealth, I think, is something that a lot of people are getting more comfortable with. COVID accelerated that in the military, especially given the challenges of moving around and not having the continuity. Really great work I know has been done in that area in the military. And then I think for some people, we need to, especially I guess we're all in the older generation now in the military life, like we need to recognize that for us, having that continuity with a primary care doctor or an APP, a nurse practitioner or something is really important. And so making access available in that capacity is also really an important thing to have. And so access is defined differently than I think we would have a generation ago or even 10 years ago. And we need to be very aware that it's different, even between 20-year-olds, 30-year-olds, and 40-year-olds. And being able to provide that is a challenge that any health system, and I can imagine the military health system, given how large it is and how complex it is really important. So it's a really great question that you pose.
This recent survey was that 71% of our respondents were either using or open to using telehealth. And that was significantly up from 30% in 2021. That's a huge, huge jump. And so to your point, like some of us, we're on apps to get, important healthcare information, to get that access. And it's different. I don't think that there's ever going to be a time where you can replace the in-person, because that's very much needed for certain interventions. However, from some of the intake perspective, what we're seeing is that some of those more administrative type appointments, that can help open the aperture for being able to serve and support more patients, because you're able to do the administrative work through telehealth or through another solution.
Yeah, and if I can add, as an orthopedic surgeon, I have to obviously put in a little plug in for musculoskeletal injuries, right? And I think my research and my just personal experience says musculoskeletal injuries are the number one type of injuries for active duty personnel, and I suspect their families, right? You got kids in high school and middle school playing sports. How we approach musculoskeletal care also may be different than, again, the traditional seeing the orthopedic surgeon. Maybe there's more easier access to physical therapists, and maybe there's other sports athletic trainers. I mean, these are different ways of access points. And again, traditionally, when I was in residency or even when I started my practice, we would never have thought about. So it's not just the, I have a cough and the mental health access too that we haven't talked about, but even musculoskeletal injuries, which I think are the number one cause of injuries, is something that we need to think differently about.
I think that point related to populations and then using the data and what our population actually is. Our uniform population is, as we all know, very young. They are all digitally native. They have expectations as to how they engage with any part of the system, and it starts with their phone. And so one of the major initiatives in DHA is our digital front door, because we need to have an app that's mobile that allows the patient to engage holistically with the system. And again, that is now tailoring and targeting for not the whole population, but the demographics within that population, because we still want, for the older patient who wants the face-to-face, they should not have to use the phone. They should be able to get the face-to-face. It's all about looking at it and what does that patient want and need, and how can we provide?
The technology perspective and the advancement that's happening there. Can you talk a little bit about that? And then I want to pivot and talk a little bit about mental health access.
So, I think that clearly there's a great excitement about the way all the digital tools can be used. And I think Dr. Malanoski said, well, we have to begin to tailor that. That means we don't look for one size fits all, nor do we just trust technology. If technology was going to fix our problem when we installed EHRs across this country that I was involved in 20 years ago, it would have fixed a lot of the problems. So it's really about how we use the technology, how we maintain trusted relationships, whether those, my digital buying experience is very different on Amazon than it is on some other platforms, right? So it's not just that there is that technology, it's how you use it, how it's incorporated, right? Particularly because healthcare is a little different. It is about trust, it is about continuity, but that continuity has to be about our data. It has to be about how we put things together so that even though I'm mobile, right, and to go back to the digital conversation, our experience working with the VA is that their mental health capabilities with phone-only healthcare, right, is just as effective in most cases, and for some populations more effective. It removes that need to come to an environment where you may have triggering events for the things that cause your mental crisis. So being able to tailor that, right, to have that mobile app, that mobile experience, more importantly, a personalized experience, can be helpful. As we begin to add other technologies on top of that, right, to be able to use that data so that I as a clinician, have a digital assistant, or as Dr. Malanoski said, my health coach has that digital assistant so they know what's going on. When I call for an appointment or I ask a question, the answers are tailored to me, for me. And then what we do is we improve resources. It's not virtual health versus in-person health. It's the best health in a continuum, because my health doesn't start and stop as a patient with an appointment. It's a continuum.
The barrier to entry, which I think, especially around mental health, one of the things that we saw in our most recent survey, which was positive, is that there is a significant increase in use of mental health support. And I think that's a good thing. As we look at the mental health crisis that's happening broadly, globally even, and the military is not immune to this, and the military has unique challenges. We've talked about access, we've talked about continuity, we've talked about frequent moves, separations, all of these things. So from the mental health perspective, what are you seeing? Dr. Malanoski, if we'd start with you, EOD has really been at the forefront of framing a conversation around mental health that destigmatizes that access. Can you talk about some of the things that you're working on and what you're seeing from your perspective?
Thinking DoD has certain advantages over the private sector. We are a worldwide community, but we are a community, and so our installations are tied to our MTS. And I think when we look at mental health, it is not just a MTF or healthcare system problem. It is a problem for the community. And so there are assets available outside of DHA on the installations that provide that first level of support to families. And I think, again, when we talk about mental health, there's a continuum of the need for support, from that individual who is under minimal stress and has good coping mechanisms to the person that's begun to have good coping mechanisms but increasing stress. They don't necessarily need to be engaged with the healthcare system, but we are now putting forward tools that they can use for, and self-help is really what it's about, but it is tools that are technology-based that will walk them through ways to improve their coping skills. And then you get engagement with the healthcare system. As we get into that, we are trying to leverage telehealth and remote mental health, because it's been established that actually mental health is one of those areas where digital appointments are sometimes preferred over face-to-face. And so we have a system-wide mechanism called Brave, where it's not local, it is across the system. And that has taken some of the load off of our MTFs related to what is a significant load related to mental health. And so while I don't want to say that we're on top of the situation, I do think we have a reasonable approach that over time will get us to a much better place in being able to deliver what our patients are looking for.
You know, when you're able to utilize those systems, you're getting constant inputs that can really be analyzed so that you can customize, support services and customize resources based on, what you're learning from the people who are accessing that type of support. So that's incredible.
We could talk for hours on where we're going related to the data and being able to leverage the data, because I do think that is where the greatest strides are going to be made. And certainly DoD and DHA sit on a ton of medical data, but the ability to combine that with other data streams gives us a holistic view of the patient. And I think that's where we have some advantages over the private sector, and being able to really see the complete life of the patient. And that's, again, where we're going.
What do you see as the opportunities coming out of that? You've sat in some really interesting conversations and had some interesting leadership roles. And so if you had all these data at your disposal, what would you do? How would you approach that?
Gosh, I mean, a lot of that without actually sitting and thinking through it can also cause lots of problems, right? But I will say it is really hopeful, right? I think what we hear about, using information to fine tune treatment plans, fine tune efficiencies, effectiveness, both the mental health and other parts of healthcare, I think have been really, really important. And I think I agree. While I've never been in the military system for healthcare, I can imagine having the data for somebody from the entrance into the military until the end allows you to really provide a really effective care plan. I think from a civilian side, how one is able to share that data and how best to be able to coordinate plans to expand if access is needed and so forth, I think is how we can help. And again, from it's really neat to see that there's been such an uptick in the utilization of mental health services provided. That really makes me happy, given how serious mental health challenges can be in society, and especially in the military community. I'll tell you, the increased use of data is great in all of those, and it can also highlight where there's deficiency. If I can geek out for a second around data around training our healthcare providers, I think we're able to. There are certain core skills that all medical personnel, whether you're a nurse or if medic, there's certain things you need to do, and there's certain things that you put your data in of what you've done, what you haven't done, what training deficiencies you may have. Having a quicker assessment of what those deficiencies are and being able to engage in systems to help you rectify that, I think continues improving access and quality that are provided both to our soldiers and to their families. So that's another maybe a little different take on data that's available that I believe is able to now be used and perhaps a generation ago was not available.
And if I could add to that, right, there's a part about data that I think we always should be honest, right? Still to this day with electronic health records, probably 80 to 85% of the data in a note that's generated today is still not in a digitized, consumable fashion. And although the DHA has done a great job with MHS Genesis, which has the world's largest HIE, those records from civilians can come in, but they come in as a CDA document, not as a computable element. And data shows only about 10 to 15% of the time that a family physician, primary care doctor sees a patient, do they actually hit that button. And since you have probably healthcare data in 10 to 12 systems, right, there's no way I can read that in a 15 to 17-minute appointment. So this is where I think we have to be honest, right? There, we need to accelerate the fact that we can get at that data. This is what AI is going to allow us to do, right? To be able to go ahead and take that note when it comes across, read it, harvest it for data. Look at my old records, because I came into the service back when paper was a thing. So they could have that information. They can have that data available. And then more importantly, don't make the healthcare staff, be it a clinician, pharmacy, caseworker, have to go through and splunk around the records. Although clinicians complain about how long it takes to write a note, they spend more time just running around the record trying to find what's there and just getting a summary to someone fast about the totality of the data. That complete view that Dr. Malanoski mentioned can make it where you decrease the care time that happens. And more importantly, you can triage the person or let them self-triage to the most appropriate level of care for their need based upon them, because we have that data. But without that data, we're just doing the same old, same old.
Yes, we go to the doctor, we pick up the records, they print it up, we put in a binder, we bring it to the new pediatrician, and it's like, okay, we're just going to hope that these get right. But then it really comes down to the parent in this case, with young kids, to really advocate. And I think that some of the things that we could lose in these transition points is some of the preventative care that's so important as we look at long-term health outcomes. And I agree, we're definitely moving the right direction, but there is absolutely still room to grow. And I also think that based on what we test and learn in the military space, it will give practical implications for other spaces as well, right? You think about the federal community in general, you think about, rural communities, you think about other transient populations. How can we apply what we're learning here and share that so that it can be used to do as much good as humanly possible? I love that. Anything else to add on the mental health piece? So we're seeing glimmers of hope. We're seeing more access to care, potentially a lower barrier to entry. But I think it's all moving the right direction here, which is really, really exciting. One of the things that's really been front of mind for me is the Exceptional Family Member Program. And I didn't put this in our read ahead, but I think it's important for us to talk about and some of those families who need additional support as it relates to specialty care. Dr. Malanoski, I know that the Exceptional Family Member Program is something that has gone through modernization and changes over the last several years. Can you talk about how you all are keeping the EFMP families front of mind as you go through the modernization efforts?
As you're aware, the key to the EFMP program is ensuring that the patient, the child, is in the right location. And so once they're there, it is a medical problem or it's a medical problem for solution. The most important thing is that they're in the right place, and that actually falls back to the services. We have a very close working relationship with the service medical departments and through them the services to ensure that we are clear as to what we can deliver in a given location, and then that the patient and their parents get orders to places where they can get the care. And we have tightened that up. We have standardized it over the past few years. And so it is more consistent between the services, because this used to be very service dependent. And it's become increasingly important with DHA being responsible for all of the facilities that the services understand how and what we deliver in a given location. So I do think while everybody tends to focus on what happens after they get there, it is a much bigger and important piece to the puzzle as to how they get there. Does that make sense?
We've heard from families historically that some have been less inclined to enroll because of fear around career repercussions or not necessarily getting the duty assignment that they like, but it's something that we know is so important, to your point, that families do get enrolled and so that they can have access to the support that they need, and really so the whole family can be thought of when creating those duty assignments. Anyone else have anything to add there? No? Okay, great. So as we really start thinking about wrapping up this conversation, you all sit in really important seats, and you all have your hands in this to some way, shape, or form, be it from a thought leadership perspective to a implementation perspective. What are some of the things that you want people to take away from this conversation and really where the healthcare system is going as it relates to military families? Dr. Moody, we'll start with you.
Yeah, I think that's a great point. And as a clinician and a veteran, I'll start with where I always start, right? We need to take care of yourself. You need to take care of your family and your colleagues, right? Resiliency doesn't come from the coffee. It comes from the people that you take care of and that you drink it with, right? So I think that is always the important thing. We are individually part of the solution, whether that you're the patient, the advocating for your child, or you're the clinician, or you're that new young doctor in the military who's got a great idea that needs to speak up of how things could occur. And then I think the other point to take home is the excitement that's out there, right? I've been around military healthcare for quite some time, not as long as Dr. Malanoski, but we've had some long-standing challenges. And now there is really, with the technology, with the advocacy that's out there, we have a way to build new collaborative healthcare that's about communicating continuously with people, meeting them where they are, and doing things differently. Healthcare is going to get better. The acceleration that's going to happen, and personally, and no bias from the fact that, I remain a proud U.S. Army soldier forever. I think the best place for that reinvention to occur is going to occur in the federal health space. In the VA also, but especially in DHA, because, again, the leadership that's there about anytime, anywhere, always care, this focus on outcomes changing to truly person-centric care. I think those are going to make that for reinvention to occur, and then it's going to accelerate. So again, as a retiree, I'm excited about it. And as a young active duty person and family, I would be even more excited about that.
I would just add in foot stomp what Ron talked about. The military health system is going to change. It is in the process of changing. It will be different. We firmly believe it will be better. With that said, during change, there is some confusion. There are some steps that we think are good and end up not being so good. And I think people need to realize that it will be better. We are getting better. But the more proactive they are in understanding what we're trying to do and where they are in the system, the better off they're going to be. And so I do not think this is the time that you should be passive about your understanding of the healthcare system and how we deliver that healthcare. I think the more proactive you are, the more questions you ask, the better off you're going to be as a beneficiary.
Where should people go to make sure that they're staying in the loop around those changes? And then, if you don't mind, just to build on that, and then we'll go to you, Dr. Jahangir. What are some of the stopgaps that are being put in place as the change is being navigated here to ensure that military families don't fall through the cracks? Of course, people need to be accountable for their role in their healthcare and their family's healthcare, but what are some of the things that you all are doing to help make sure that, the support is there when families need it?
I think we're being careful in how we roll out new programs. And so we don't want people to take away the impression that we already have it when we don't. And so I think the way to ensure that we do this right is to be careful in how we roll things out. We do have a DHA website that is specific to DHA, and we can provide that link. And that is really where I would go if I were a patient, to be kept up to date on what's going on with DHA. And again, I think the advantage that we have is that tight linkage between, certainly for our active duty family and dependents, the line and medical. And so we take care of them either through their line, they can access through their medical departments, and then through us. And then for the retirees, again, we try and communicate through the MSOs, VSOs to ensure that we're getting message out there.
Yeah. So, as the outsider, if you will, from here, what's been really great for me in my over a decade now privilege of working with the our military colleagues in healthcare is for your audience to know that I agree that the best innovation, the best dedication to patients, the best access is truly the goal of the leadership of the military healthcare leaders I've interacted with and the providers I've worked with. And what has been really neat for me over the past, call it 5 to 7 years, is the willingness to partner with civilian institutions like ours to continue to increase that access and increase the specialty care and to provide cross collaborations of education. As much as a military provider may learn from us, we have learned from them at our civilian institutions. And I think the willingness of the Army, the Navy, the Air Force, and others to collaborate with us, I think has been a really great asset for not just the military families and service people who are being taken care of, but the civilians who benefit from their care too. So for me, it's been, I know the commitment's there. Again, as the outsider, it's very evident. And I think if I was in the inside, I would have a lot of confidence to know that continues. And I was mentioning before in the podcast, General Crossland, I've had the privilege of knowing her since she was Colonel Crossland and the commander at Blanchfield. And I know her commitment, and just like everyone else in the military, commitment to make sure that people are taken care of, I've seen firsthand. And it's really, as a citizen of this country and grateful for what all of you do, it's really neat to see that.
I think we'll say 5 to 7 years ago when we talked about the private sector, that was competition. And we have really shifted how we think of this. It is now about partnerships, strategic partnerships to better take care of the patients and finding where we can mutually support each other as we do the important work that we do. So I think it was an excellent point, Alex. Excellent point.
People don't care who they get the support from or where they get the support. They care they get the support that they need. And so this podcast is really about making sure that we're connecting the data to these important conversations, but also connecting industries, because at the end of the day, we're all in this together and we all want the best possible outcomes for military families. And so to each of you, I want to say thank you so much for joining us for our inaugural podcast. Thanks for being our guinea pigs. And really, we're thrilled to stay in touch. If there's any information that we can get out to our audience, I definitely want to get that DHA website out. But I think that the other piece of it too is from a peer-to-peer model, the more that military families can be aware and share that information, the better off we'll all be. It's really important to make sure that we're all in the loop. And so to each of you, thank you so much for being here with us today. And thank you for everything that you do. Have a great day. A special thanks to the MFAN team and rockITdata for making this podcast possible. And to our listeners, thank you for tuning in. You can listen to this episode and more on Apple, Spotify, or wherever you get your podcasts. If you found today's discussion to be helpful, please subscribe, leave us a review, and you can share today's episode with others who you think would benefit from it. We would love to hear your thoughts. You can find MFAN on Facebook, Instagram, LinkedIn, X, YouTube, and you can always connect with us on our website at www.mfan.org. Until next time, let's go where the data lead us, and let's make life better for military families.